Is everybody breathing? Breathing something we do 21,000 times a day. Think it's important? So this afternoon, I'm going to teach you everything that you already know. But I'm going to put it in a context perhaps that was a little bit different. So, based on this idea, malocclusion is the solution to the body's need to seek equilibrium and homeostasis. Okay, so this is my famous stack of blocks. We've got a stack of 3 blocks. We're going to put a 4th block on top. Where are we going to put that block to seek equilibrium and homeostasis? Anybody get an idea? Right on top, right. Yeah, we're going to put the blue block on the yellow block, and that is in balance. We know that because perfect alignment up against gravity is most stable. If we use this as a metaphor for the body, we call it competence. And in orthodontic terms, we call it angle class 1, right? Solve this one now. 3 blocks. We have to put the 4th block on top. Where are we going to put the block? Off to the side, yeah. We're going to put it a little bit onto the side. And the idea is we had to change the rule a little bit for balance. And if the blue is the upper jaw teeth and the yellow is the lower, then what we have here is a compensation. And in orthodontics, we would call this a class 2 or class 3 or whatever it is. It's a malocclusion. Right? But it's in balance with the rest of the stack. So if we had to articulate a universal rule about this, what would it be? Would it be that we put the blue block on top of the yellow block? Or would it be we put the blue block on the stack where it's going to balance best against gravity? Which of those would be a more universal thing? Right. So the thing is, when we say we put the mesiobuccal cusp of the upper first molar into the middle groove of the lower first molar, which rule are we using? The wrong one. Right? And I just didn't understand that when I learned about angle class 1. Angle developed class 1 because people already had straight teeth. Their teeth were in balance with the rest of the body. So if the body seeks balance and we're using angle class 1, what are we doing? It's going to be imbalanced and the thing's going to fall apart. I mean, in reality, that doesn't happen all the time, or maybe it happens a lot more than we think. We just don't see it. So what do? We roll in another compensation, which is our retainer. And everybody knows that you have to use retainers forever if you're going to keep the teeth perfectly straight 90% of the time. Yeah. So the problem, of course, with this approach is that you're leaving an imbalance somewhere else in the system, and eventually that imbalance will likely express itself, and again, things are going to fall apart. And they fall apart in ways in which we, as dentists, have had to deal with for many, many years, but just were perplexed about most of them. Each one of them seemed to be a separate problem. and often without answers. Multifactorial again. And then, when I hear multifactorial, that means I can pretty much forget it because we're never going to figure out the factors. But now, with the string theory in tow, a way of understanding what's going on, and it envelops a lot of these things that we've struggled with. So I'm going to briefly talk about, again, things you already know about, but try to do it in the context of airway. So we call these the airway-centered disorders. The nasal congestion, the tongue tie, the open mouth posture, the soft tissue dysfunctions, the hyperventilation, the sleep, breathing disordered sleep, the parafunctions and habits that seem to go things awry, the bad results in joints and facial pain, the bad rest of the body, posture-wise or function-wise, and when you get to crooked teeth, it's just the icing on the cake. All right? So, this is my air conditioning guy. He yells at me 4 times a year when he comes over and tells me that I haven't changed the filters. And I know better. I'm a terrible housekeeper, that's all. And because nasal breathing is particularly effective at processing air in a way that makes it easier to breathe and easier to process for respiration. Cleans, filters, moistens, sterilizes the nitric oxide from the sinuses and so forth. And it really is important. Functional breathing looks like this, and thank you to Roger Price. How many of you guys have ever heard Roger speak? Yeah. Roger was in residence with me for 4 years. He's out west again now in Albuquerque, right? And he helped me put a lot of this stuff into practice. 8 to 10 breaths a minute at rest. For kids, I say 12 to 14. The minute volume is an important metric. So the number of liters per minute is one way to look at how we're processing it. It goes in and out through the nose, even if you're doing yoga, driven by the diaphragm primarily. It's silent, no turbulence, right? And it results in optimal CO2 levels. In this way, oxygen is best delivered to the brain, the muscles, and the organs. All right, Mark went over that. That's Henderson-Hasselbalch. That's the Bohr effect. That is, you have to have the pH shift proper for oxygen to jump onto the freight train called hemoglobin. And then there has to be that slight shift in pH for it to jump off the freight train. If you don't have that shift in pH, it's like the freight train passing the station. Well, I mean, it's not like you don't get any oxygen, but it's probably more like running your car on 80 test gasoline than 94 test gasoline, right? It's just not an efficient way to process the fuel. And that's functional and balanced breathing. Interestingly enough, in 100 years ago, and I understand in Juneau, Alaska, where the air is clean, people used to breathe at 6 to 8 breaths per minute. But over the years, we have started breathing faster and more. Why is that? That acceleration in the curve probably parallels the increase in heart disease, diabetes, obesity that we also see in the population. The acceleration of the use of high fructose corn syrup, for instance, and other processed additives create a tremendous amount of stress on our body. that the body has to cope with. In a sense, our bodies have to work twice as hard to either sequester, destroy, or eliminate a lot of the things in our modern environment that we're exposed to, whether they're chemical, electrical, nutritional, stuff we put on our skin, stuff that comes out of the industrial carpeting, and the lights that man never lived in until a little over 100 years ago, and all that kind of stuff. So our bodies work harder. In healthy breathing, you may have 6 liters per minute. But in almost every chronic disease, there is a dramatic increase in heart rate. Heart disease doubles that rate. Asthma doubles that rate. Sleep apnea doubles that rate. So you're actually processing more air than you otherwise would. And the more air that you breathe, especially if you're breathing it hard or fast or opening your mouth, you take in air, and air has more than enough oxygen. There's 21% of oxygen in air. We only need 6%. That's why you do, artificial respiration. You have plenty of oxygen in your outbreath to keep somebody alive. But when you blow off too much carbon dioxide by overbreathing, you're actually lowering your reserves. Why do we need carbon dioxide for reserves? Because it's not in the air. We have to create it. We create it with digestion. We create it with muscle movement, metabolism. Those two are the biggest. And we need to store it in order to properly maintain pH and smooth muscle balance. And when we overbreathe, we tend to expel more of it. And over time, little by little, those levels go down on a chronic basis. They go down because we could lower our CO2 levels and not stimulate breath, and then we would stop breathing. That's not acceptable. So over time, we start lowering the threshold of what CO2 levels there need to be that make us breathe. And chronic hyperventilation slowly, slowly, slowly lowers down. And then we see people like this. This is very common for me to see in practice. I see a lot of kids at 35 or 34 or 33 millimeters of mercury, pressure in the breath. But I also see a lot of kids in the 20s, 25s. I don't know how they're doing it. 21 breaths per minute is actually moderate in my practice. I have some kids coming in at 25 breaths per minute, 30 breaths per minute. That's like a little bird. So we're going to go down this list of airway-centered disorders just to go over them. Again, this is a lot of stuff that you know, but think of it a little differently this time as I go through it. So things like enlarged tonsils, nasal constriction, deviated nasal septum, enlarged turbinates, cysts, polyps, and allergic rhinitis are all the kinds of things that create that Starling resistor in the nose. And of course, if you can't breathe through your nose for whatever reason it is, and whatever age it is, you're going to default to some way where you can take the next breath. And that leads to a whole host of problems. I'll get up close because I know you can't see this. This comes from a chart by Kent Lawson, who wrote about this in his first book some 20, 30 years ago. Pink is blockage of eustachian tubes, mouth breathing, low tongue posture, mandible with lowered and retruded posture, and forward head posture and shoulder posture. Those are the immediate effects. And then from there come all this, which you'll have in your PDF. It's really interesting to take a good close look at this flow chart. But they include the things that we deal with every day: the constricted, underdeveloped maxilla, the high V-shaped palate, the malocclusion and loss of vertical dimension or extra vertical dimension, however it goes, open bite, long face syndrome, retrograde, craniofacial dystrophy, basically, right? So all of these factors, especially craniofacial dystrophy, it's a primary risk factor for sleep disordered breathing. If the face doesn't grow well, the airway doesn't fill out. I mean, it's almost as simple as that. It's not in every case, but very common. Now, we've all been talking about tongue tie in these last several years quite a bit. And I think Mark is absolutely right in that we may have overshot a little bit, especially the way lasers have made it so easy to do the procedure relatively more comfortable. I think we're also sometimes paying attention to the tip of the iceberg, because fascial restrictions can be in the tip of the tongue. They can be in the middle of the tongue. They can be in the back of the tongue. Sometimes the ones on the very tip of the tongue, the ones that we always used to call ankyloglossia, they may not be as bad as others because the dorsum of the tongue can still get up to the palate. May not be so good for eating ice cream or French kissing, but it can be really good for, maxillary development. It's the ones that are a little further back that hamper the dorsum from getting up on the palate. So it is going to be important for us to do two things. Number one is we've got to maybe take a little bit more functional look at this and not just try to release every tongue that we see, understand where the problems are. To find techniques that don't create more scarring. And that's got to include both pre and post-op physical therapy, which essentially is myofunctional therapy. And then also understand that the fascial restriction that we can see on the tongue here, this may be just the very tip of it. Fascial restriction can go anywhere in the body. Especially you guys that know cranial, I'm sure there's some of you who know it a lot better than I do. You can feel things from the head that are originating in the hips and even the feet and so forth. And just to release the one on the tongue may be undershooting the problem. But we do know that there is some evidence that restriction of the tongue can influence the way we breathe. This particular study with Guilleminault and his co-workers there tried to separate out the difference in children between those that are getting corked up by large tonsils and adenoids and those with frena, and found that short lingual frenum can be an independent risk factor for OSA in children. So little Ben here at 5 years of age, showed something that we see all the time. His dad had 2-jaw orthognathic surgery. They came to me because they didn't want Ben to go through that. And I had a little bit of a time trying to get this untangled. Of course, I'll talk to you about this tomorrow, but I try with dealing with the behaviors, get the tongue on the palate, see if the tongue can help create the problem. But this is just something that, as dentists, a lot of times we don't even see the tongue, right? The tongue is only something that gets in our way while we're trying to do our work. Or at least that's the way it's been in the past. Now we're starting to understand how the tongue is really not only the elephant in the room, but it's the king elephant. It rules the roost. So when you start to learn to read the tongue, you start to see things that I never saw before, and that indentation there is just an indicator of that freedom restriction. I used MyoBrace for several months, and he was a good kid. He was really doing what he could. We got through the incisors coming in, but we still had some of the crossbite. So then I went to I don't think we really need to listen to this. We went to an ALF with reverse pull headgear, and again, he was really good. I made him record this, and all right, this is
Beautiful.
funny.
How's that feel?
Good.
Yeah, not too tight?
No.
All right. And you can talk with it?
Yes.
And you can sleep with it?
Yes.
And you can't eat with it?
Yes.
And you can't kiss with it either?
He's a good kid. So, and I was able to develop the maxilla. That's a photocopy of where we started, and I use that as a regular practice aid there. And then we had the tongue released, and you can see the dorsum of the tongue is looking better, but still look in the back. You see some pull there, and it was just a laser that we used to relieve that. We did the labial frenectomy. That's the wound right there, and it tends not to look so good after a while. It can scar up again, even if you sometimes do good physiotherapy afterwards. But we're getting closer to untangling this for him. So open mouth rest posture. I touched on this a little bit at the end of the first lecture. This again is kind of the string theory, because so many chronic stressors lead to it from the moment we're born, to our early feeding, to our early chewing, to threats to our breathing, to anything that raises the metabolism, to stressful levels, causing us to overbreathe, having to get rid of all that excess CO2. And they all have consequences. This open mouth posture is full with unintended consequences, and the consequences lead back to become stressors themselves, and so we get into that vicious form or function spiral. This is actually this girl's rest posture. This is, and if anybody wants to sit me down with a beer tonight, I'd be happy to talk about this case because I need help with it. But this is not the girl opening her mouth. She is standing there looking out the window, and her occlusion is just monstrous. Probably going to be in my top 10 career cases here. And management-wise, she was impossible. She would jump out of the chair and run and hide under my chairside unit. The girl, unfortunately, really had a lot of issues. And one issue was parents who were just delightful and nice and really didn't think anything was wrong with this girl, except maybe she had a crooked tooth in the front. These are really, really challenging situations. Her posture is dreadful, and so forth. And I got to a point with an expansor and a lower sweep expander, but the undercuts, because of the collapse of the alveolus, they were so great that she would scream at the top of her lungs. You know how ortho offices are. We got 5 open bay chairs. Nobody screams in an ortho office, but she screamed. And as a step back, I went to Alf's because they're a little more comfortable to put in, and we started to untangle the arches, and I think I'm going to be in pretty good shape there. But the skeletal distortions are so bad. I mean, I've been talking to the parents about eventual need for orthognathics. If any of you have an idea of how to better approach this, I'm open for discussion. All right, myofunctional disorders. I know you understand this, but learning to see it is a critical thing, just because the myofunctional disorders themselves are symptoms. They are themselves compensations for an inability to breathe well. Otherwise, you wouldn't have to push your tongue forward to get it out of the back of your mouth. And when you push your tongue forward, it's not going to be on the palate to swallow. And if you can't create a seal on the palate, you've got to create a seal on the palate with your tongue alone. Then you have to recruit other muscles to help you create that seal so you can swallow your food. And they are the lips, the chin, the cheeks, the neck, even the eyelids. So once you start seeing, oh, and by the way, thank you to John Flutter, one of my first mentors in this field, for these incredible videos. We look at each one and parse out a good dozen dysfunctions for each of these kids. Aberrant swallowing patterns can come from lots of different things. They could be developed from an inability to transition properly through neural reflexes. We've been paying quite a bit of attention to how reflexes need to make a transition properly, and oftentimes that they don't. When you can't breathe through your nose, it becomes a compensation in and of itself. And then these chronic issues that kids and adults, suffer through. I mean, I don't know why we want our kids to suffer 7 infections a year before we'll do anything about it. It just does not make sense to me to wait that long. That's 7 times, the 2 or 3 weeks that a kid claims to have a cold, that they actually have to walk around with their mouth open. I mean, that's going to become more than just a transitory cold. We know it's not just the swallow that creates this. This research from many years back talk about rest posture as being the most influential element of eruption and development of the maxilla, which is so plastic and so subject to its functional matrix. And just like Harvold's monkeys, the way the teeth come in has more to do with serendipity than it does with some kind of natural facial pattern, brachiocephalic, class 2, blah, blah, blah. That it's really the muscles guiding the teeth into place, dependent upon which of the muscles are compensating in what direction. And there's, almost endless variations of that. So this was a big change for me to understand that. I now come to see that crooked teeth are very much like the bear tracks in the dirt. You don't need to see the bear to know the bear was there. You don't even want to see the bear. You got bears up in Juneau? I actually have bears in Jersey. Yeah, they come out into the suburb. I do not want to see one of those things. But it's enough to see the evidence. When you see crooked teeth, it's just a sign that soft tissue dysfunction has already been there. So, I've made lots of mistakes. I'm sure you feel that way too as you look back on your career. Mom brought this kid in because she didn't like the way his front tooth looked, right? And this is what I saw.
Oh my God, you're a carrot chewing machine.
Bunny rabbit.
There goes Oscar. Oscar, please come sit over in the chair.
What do I have to do?
Just eat your carrot.
We're taking pictures for your file. Remember, we did that with Nancy.
Wise guy. Yeah, that's the question. Are his teeth his only problem? And I made the mistake, or at least at the moment I thought it was a mistake, of telling his mom that her child was really sick. And I did use that word. It's the last time I used the word, because when she grabbed him and walked out of the office, I learned that I needed another way of communicating these problems to moms. We do have to be careful how we talk and the things we say, but it is possible that those inopportune words that I mentioned to her then, maybe they'll come back to her or to him someday and he'll get the help he needs. But it's a lot more than just crooked teeth. I know you know that. The chronic hyperventilation and hypocapnia comes from the urgency to take the next breath. By and large, I find this is an issue that we talk about a lot, but there are very few other physicians that talk about this. You can find some studies here and there, but it's bugged me that when I go to the sleep meetings and talk to the sleep physicians, they're worried about hypercapnia. You know, when you go through an apnea, your CO2 levels rise, and they're going to see that when they do their PSGs. And so they think it's a problem of too much carbon dioxide. And when I say, no, it's a problem of too little carbon dioxide, so that even a small rise, even if it's going towards normal, feels very uncomfortable to them. So we talked about what functional breathing is. Basically, when you have snoring or mouth breathing, your minute volume increases, CO2 levels drop. Now, I didn't say this before, but end-tidal CO2 is equivalent to blood level. That's something that's been studied. So that's why the capnometer is a valid way of understanding what PCO2 is. pH fails to reach 7.35. You get the Bohr effect. Supply to oxygen drops in the brain. Hypoxia develops. And it's that intermittent hypoxia that's so damaging. So what does the body do? The body automatically tries to get back to equilibrium and homeostasis, and does so by trying to build up the CO2 buffer again so that oxygen can get to the brain. So what happens is that you have an automatic response to halt breathing. So if any of you have been doing a crown prep on number 2, and you find yourself holding your breath, there's a good chance that your body is trying to make sure that you're thinking clearly. Breath holds can, in fact, be the source of central apneas. And I've never heard a physician say that. They're thinking that it's a neurologic deficit, where it may be the body just trying to retune itself, raising CO2 levels to release more oxygen. In other words, central apnea may be a physiologic compensation in itself. So you stop breathing for a moment, CO2 starts to rise again, pH goes where it's supposed to, oxygen's released again, and you've averted the crisis, but then you yawn, you gasp, you start breathing inefficiently, especially during stress, which we now know happens a whole lot of the time. And your CO2 starts to fall again, and you get into this vicious cycle where O2 is decreased, but perfusion is decreased, And we now know also that this intermittent hypoxia is the most damaging thing you can do to your brain. It's a very different thing than obstructive sleep apnea, where you get these severe decreases in oxygen saturations, which are no doubt very taxing on the body, taxing on the heart, taxing on the vasculature. But intermittent hypoxia seems to like fly under the radar, because you may only drop 2 or 3 or 4%. And then your body kicks in and tries to rectify it and raises it up, and then it drops again, and it kicks in and raises it up, and you get this cycling of up and down oxygen, which never gets to a physically dangerous level, except in the brain, where it starts to interfere with both growth and development and maintenance of the brain. So we see, loop gain. So we see this in obstructive sleep apnea. I mean, this is David Gozal's and his wife's work. We really haven't studied this intermittent hypoxia or the upper airway resistance in kids. It's, we've just been concentrating on the OSA. But you can find the presence of brain injury where the brain cells can either thin out or they can thicken up. If they thin out, it's because they're not developing the way they should, or there's neuronal injury in those areas. As a result of the changes in oxygen and the sleep fragmentation. And this is really what we're all about, is looking at the intermittent hypoxia and the sleep fragmentation. And then they can get thickened because there's supposed to be this cycling of certain neurons growing when they're used, and the ones that aren't being used get pruned away and all that kind of stuff. So that can be disruptive. And also, it's inflammatory. The brain gets inflamed. It starts off inflammatory processes when the oxygen rises and falls like that. It's just really noxious. So another study, this is Ron Harper's part of this one too. He lectured for us in our first year. We were really happy to have him there. He shows that between an AHI of less than 1, and that's really kind of the minimum, that's the maximum we want for a kid, and then kids that have numbers that are higher than that, 7.5 is like most for adults. That's nothing, at least according to insurance companies. But he shows that there's both chronic and acute damage to the brain, and these are many of the areas which also control the autonomic nervous system. So that's really important, because when you stop breathing, you need your sympathetic nervous system to jolt you with adrenaline so your heart beats faster and you get your oxygen back up. When this happens over and over again, your defense system is dying. And that's where you get to sleep apnea someday, because you're no longer able to react to that threat. It results in behavioral problems, lower IQ scores. This mothers will listen to. This trajectory for your child, there have children that have lost 10 IQ points. I mean, we're putting them in soccer because we want to get them into college. Let's nourish their brains because we want to get them in college. It seems to make more sense to me. And that sometimes these interventions have to start as soon as we see it if we're going to make a difference. I mean, the brain is plastic and it will, adapt. But under chronic injury like this, you have to have aggressive, sustained, or alternative treatments. Now, this article didn't realize what we're talking about, which is breathing through the nose, holding your lips together, and putting your tongue on the roof of your mouth. That's the kind of aggressive, sustained treatment that we need for these kids. And even for adults, this work by Avram Gold he's considered sort of a rebel in his field by talking about this. There are so many people that we've waved off in dentistry. They're just crazy. There's no reason that they should feel this way. It must be some emotional thing. But emotional problems can be the result of long-term chronic pain. We all know that. They also could be the result of long-term inability to breathe well, the intermittent hypoxia, the lack of bad sleep, the emotional drain of not having slept well the night before, and so forth. There's your loop gain gets worse and worse and worse. So you don't have to be old and fat and flabby to suffer this way. There are all these things that lead to the functional somatic syndrome, now called central sensitization syndrome, chronic fatigue, fibromyalgia, chronic pain patterns, depression. I mean, this is a large problem. If people could feel better just by getting oxygen, wouldn't that be a wonderful thing? And that's where we're headed. Now, this breathing disordered sleep. Again, it's breathing that disorders sleep, not sleep that disorders breathing. It has taken a toll. This is my Jersey example of this. Tom fell asleep as he was driving a train into Hoboken train station and forgot to put on the brakes. And what's our compensation? Now we're going to put in automatic braking systems. Instead of helping people get a good night's sleep and being awake enough to do their job. So the comorbidities of poor sleep and poor breathing are too numerous. No, not too numerous. They're numerous, and we have to mention them. And the people that are in their silos treating each one of these comorbidities have to realize that oxygen is at the core of the problem. And it makes sense, right? How long can you go without, holding your breath? And so even if you get uncomfortable, how do you think your liver feels? How do you think your heart feels? All these organs are very sensitive. Our brain only can last for 4 minutes without oxygen. Now, why do we think that depriving it of 5% oxygen is really such a good thing? Because we can get up and walk around and smile. It takes its toll after a while. So, the adage, we talk about this adage all the time of the elephant and the blind man. When you talk about heart attacks, migraines, obesity, diabetes, natural death, at 4 o'clock in the morning and so forth, you think that's such a nice way to die? That's a heart attack because of suffocation and so forth. So we have to start bringing that all together. Now, the signs and symptoms of sleep apnea, the frequent snoring, labored breathing, the gasping and the noisy breathing and so forth, enuresis. A lot of people, I have moms come in. I had an 11-year-old that's still wetting her bed, and they have her in a diaper. I mean, nobody's been able to help her. They do the alarm and this and that. Sleeping with the head back, headaches on awakening, daytime sleepiness, ADHD. Steve Sheldon out of Chicago says 70-80% of kids that are being medicated for ADHD, which they're being medicated for at 3 years of age. 3 years of age for CPAP now too. That this is really a breathing problem. It's a sleep problem. These kids are not getting good sleep. And we're not looking at the right part of sleep. We're just looking for apnea. And we're missing that whole boat. All the physical things that we look for each and every day, those are just signs and symptoms of the problem. So when Mark and I say that we ask this question, how much distress are these kids in? This is the bottom line. And it's not only daytime.
Sleeping and holding his head up.
Good, isn't it?
Why is he sleeping and holding his head up?
He's the
Yeah, especially while he's sleeping. Well, I can do that too.
Oh, now it's a party trick.
Close. Let's see. Oh, you want to force
Because when he lifts his head, he's choking on his own tonsils or sputum or whatever else was in there. That's why he's sleeping with his head up like that. Do you ever take a balloon untied, you blow it up, and then you try to make it whistle, or you close it? That's what that sounds like, right? That's the airway closing off, negative pressure with every single breath. That's Stridor. So this is a brand new case that we just worked up. And this is the portfolio, not necessarily in the order we usually present it, but you can see the mandibular retrognathia there. And class 1 occlusion. Somebody would love to just put braces on this girl and straighten the teeth, right? And they could have easily found that. In fact, the family has an orthodontist already. Orthodontist said, we're going to put you on recall, and when we're ready, we'll do your braces. Because it's an easy orthodontic case. Can you imagine retracting the incisors on that face? And the parents have struggled with this kid for years and years, ever since birth, with things that kind of came and went. Usually without explanation or resolution, but they just sort of went away. And physicians are very quick to say, oh, they'll grow out of it. It's normal, like swollen tonsils and trouble breathing and distress in breathing, because we don't seem to have the answer to it. But I don't know, to us it seems like the answer is so obvious. They're having trouble breathing. Acute episodes, struggling to breathe, sheets are a mess, head is cocked back when you sleep, tongue tie, open mouth eating, texture aversions. That's the mouth saying, don't get in the way of my airway. I don't want to have anything that requires chewing. She only eats soft food for years. She woke up with a witnessed hallucination. You know, her eyes were like bugging out, and her ears were really sensitive because she had gone through, a hypoxic event. And they just couldn't explain. It was only one time it happened. So, all right, we'll see if it happens again. Unexplained aches, latching issues, ear infections. She would choke on a bottle that they opened up the hole on, and that kind of thing. So all these kinds of symptoms. We use a quality of life questionnaire. I'll explain it to you tomorrow. But we're looking at major systems here that are all related to breathing. Breathing through the nose, keeping the lips together, chewing, swallowing, standing with good posture, eating nutrition, daytime breathing, getting a good night's sleep, breathing while sleeping, tooth grinding, body aches or pain, behavioral issues at home and school. There's sort of like subcategories of those. I have the parents rate the kids. And usually if I do this before we start treatment, they underestimate. You know how parents are. They don't want to admit anything's wrong with their kids, or they don't want to make the treatment more expensive than it has to be, one or the other. So, you get a certain amount of underreporting, I think. That's our collaborative team. There's the face, no surprise there. I did a little photoshopping. I'll either do some photoshopping like this, or I'll just have the kid posture the jaw forward and show how much better the face looks when the jaw is forward. And that's often, of course, in the presence of a deficient maxilla. So definitely a tongue tie. So she gets her tongue up there, but look, the whole floor of her mouth is up there too. So that's a compensation. her posture is forward. We use a sort of a tablet with a program that helps us measure posture. Nothing unusual here in the pan, but definitely narrow arches. Not as crowded or as poorly formed as you would think. I mean, you could definitely get plaster on the table by putting on class 2 elastics here. But look at the back of her throat. I don't do very many cephalometric tracings anymore. I know sometimes GPs get really thorough about it because you need to sort of justify the fact that you're doing your job. But I went the other way. I learned every analysis in the book, and I realized none of them tell me anything about what happened to the face. They tell me where you are now, but they don't tell me how you got there. So I don't look at that so much anymore. Even looking at airway volume can be a little bit deceiving. And in fact, I wrote volume. I don't even look at volume. We look for the Starling resistor, basically. And she definitely has one. I mean, right there and very commonly at the very drape of the soft palate. The tongue is back there. The soft palate's being held back there, and she's very narrow in that area. And I showed this to the mom, and mom started crying. She goes, "I knew it. I knew this child was having problems, and nobody found it for us." Frankly, I hope I have found it and can get the girl out of it. This very well may be an orthognathic case, and I'm sort of thinking that right now. We're going to be doing consultation with a sleep specialist, with a myofunctional therapist, with a orthognathic surgeon, even though she's 11 years old. If we're not going to do early surgery, which there are some people that are starting to do early orthognathics, then we're going to have to stabilize her sleep somehow. Whether it's with CPAP or maybe a mandibular advancement device. All right, guys, you guys can help me on this one over beer. Tell me, is there a way that we can help those jaws grow? Bill, I'd be happy to sit down with you if you think there's a way to do orthotropics on that. Yeah, all right. So, that's kind of confirmation. I've been so positive about the things that I've been doing in practice that when this girl came in and my staff goes, "Oh, I can't wait till you see what you're going to do with this one." And the staff kind of is trained to help usher people into treatment easily, and they got her started, took impressions for the BioBlock, and I was busy and I walked away and I forgot to tell them I'm not so sure about this one. So it was a good hour and a half consultation, 2-hour consultation with the parents to explain why I don't think we're going to be able to help her grow out of this. But that doesn't mean I'm going to wait till 18 to do anything either, because this girl is in trouble. She is in distress. Sweet kid. And now she plays soccer and she's pretty athletic and that kind of thing. But when these are videos, but I'm going to skip them. When you look at her breathing pattern, she's breathing at 30 breaths per minute. And we sit them down in the chair and we tell them to relax and put on the cannula and just breathe. She's not sitting here scared. She's not in fight or flight any more than she would be if she were sitting in front of a TV, right? But when we look at her, I'm going to show you her HRPO in just a second. I do want to jot this down. This is a validated sleep questionnaire specifically for children. They have 2 versions. One of them is for kids up to 10 years old. And then the other one is from 10 to 18. And it's been validated at 3 universities. Take that off the tape. It's been validated at 3 universities. It is available online. So for $16, the parents can go on and they can do this. Or you can buy it for 60 cents a piece and have it on your computer and then do it for them. They answer the 50 questions, and then it immediately gives you a graph. The graph looks at 4 different major categories of sleep disorder: obstructive sleep apnea, periodic limb movement disorder, delayed phase sleep phase syndrome, which is basically just bad sleeping habits, for the most part, excessive daytime sleepiness, which you see that sometimes in kids, but usually it's just the opposite. They become hyperactive when they're not sleeping well. And narcolepsy, for what it's worth. I mean, there may be a very small number of people that fall into that of kids. It gives you a sleep disturbance index and a percentile ranking. So she didn't really cross over the barrier into the yellow area in any of them, but she came pretty close. And I even though this is a validated questionnaire, I don't put entire faith in it. Again, because sometimes the parents are under-reporting on the scale. They rate things on a scale from 1 to 5 as far as seriousness goes. So, but they're all put her over the 50th percentile. And anyway, so now we also look at the high-res pulse oximetry. Here she was moving around and knocking the sensor off her finger a lot. Not too many apneas. By the way, the software we use tries to correct for the errors. Like if you're knocking it around and see how the blue lines drop, that's oxygen. That doesn't mean she died at every thing. It's just, those are just, that's noise there. She had 6 hypopneas an hour, 7 respiratory effort-related arousals, meaning struggling to breathe every hour. This one, I kind of think this was the most representative night. We got a good, we got 4 hours of actual recorded time. But again, not really apneas, not severe drops, but a lot of distress. 10 times an hour, every 6 minutes, she would have trouble breathing. So just to, that's supposed to come in front. How do I do that? Wait, hold on. I want to correct this because it is good to see. This. No. Wait. Oh, for Pete's sakes. Come back. Mark, I don't know the software. Okay. All right. Well, all right. You'll be able to see it. So look at the green square there, and the blood oxygen is very even, and the heart rate is very even. That's stable sleep. But look at the epic right next to it. Look what's going on with the oxygen. See how it's going up and down and up and down. It's still 95, 96, 97%. She's not in danger there, but look what her heart is doing to keep it up there. She is actually spending 22% of her night fighting to keep her oxygen up. How peaceful sleep is that? What's your heart supposed to be doing when you're sleeping? Not acting like you just ran up and down a flight of stairs. And she's young. This is a good thing. It means her heart is doing its job, but it's a bad thing for sleep. So, yeah, all kinds of things to be done. But the assessment is fragmented sleep and breathing dysfunction, secondary to severe mandibular retrognathia and narrow airway, and on and on and on, suboptimal airway and breathing patterns and that kind of thing. So it's going to be a lot of work. Back in 2012, when Karen Bonnick did that study up at Montefiore that showed that even an infant, if she was snoring at a year old or year and a half old for 6 months and it went away, that these kids would still be subject to more neurocognitive and attention deficit, neurocognitive dysfunction and attention deficit by the time they were in first grade. This is how susceptible the brain is to damage from bad breathing. And this is why we no longer say that snoring is cute. It is a red flag. It is a hallmark for bad breathing and bad brain health. And we've got to take it seriously like that. Anne Halbauer, who is very active in the American Academy of Pediatrics, that came out with a statement about obstructive sleep apnea in children some years ago that said that TNA could be a first line of defense for sleep apnea in kids. That was a big step for physicians. Really, physicians are not supposed to be waiting for 7 infections a year. And that's Steve Sheldon. Whether or not autism causes bad sleep or bad sleep causes autism, I don't think it matters really, or at least we don't know yet. But what we know is when you throw a lot of good stuff at autistic kids, they can come out of it. And one of them has got to be oxygenating their brain. I mean, how else? When somebody has had poor sleep for 3 months, they either have a psychological problem or a physical and psychological problem in combination, because once they have poor sleep, it becomes an issue in their lives. That's Rafael Pelayo at Stanford. The common teaching is that sleep disorders in children will go away, but the reality is that they don't. And so it behooves us never to ignore a sleep or breathing problem in a child. And Mark showed this before. These are the kids that are trying to transition to mouth breathing, but they cannot. Their structures are already damaged. Their breathing is damaged. They just can't figure out. This is the one Harvard monkey that didn't make it. And this has got to be heartbreaking, not only to parents of kids like that, but to us as their protectors and healthcare advisors, that we cannot let this happen. We cannot let this happen to children. All right, bruxism and parafunctions. When there's a chronic stress or mechanical flaw in a system, the body will compensate. I hope you come away with this word compensation if you don't already have it in your vocabulary. I did not have it. I didn't really understand it. Jen Talla, the IBCLC, who has a deep understanding of myofunctional things in kids, taught me this, that kids compensate. We all compensate. And frankly, every weird thing that we do, like, I don't know, shaking our foot or bouncing around or tipping our head back or whatever it is, it's because our body wants us to do it. Our body knows how to make a problem not go away, but at least how to deal with a problem. The compensations for chronic stressors can be pain and paresthesia. They can be parafunctions, and they can be anatomic distortions. I learned this from another one of my mentors, I guess, who's often here, right? Gavin James. All parafunctions, even when destructive, are serving a purpose. Every pattern of wear tells a story. Every malocclusion tells a story. Our job is to understand what it is. We are the Sherlock Holmes of the mouth. Isn't that true? So, when we can do something well, like breathing through the nose, things turn out really well because we're competent. So you get a nice wide palate and so forth. And when we can't do things well, we have to compensate. And that compensation has its own, it has its purpose, but it also has unintended consequences. And then you get into that form and function spiral that either goes towards ill health or to good health. So around and around it goes. And I know a lot of people kind of argue, you know, dentistry, man, we can polarize about anything, right? What's the best toothbrush, probably. But this form and function spiral is something that we polarize against. You know, some people will say function creates form. And, you know, myofunctional therapists will get us out of every problem. And orthodontists go, no, form creates function. I'll make a space for the tongue and it'll find itself. But that's ridiculous. It is. It's not an or, it's an and. It's form and function, and form and function, and form and function, either going downward or upward. And we have to start looking at that. So when we talk about parafunctions, we have to start thinking compensations, not just things that are. Oh, she clenches her teeth. Oh, she bruxes. That's not a personal characteristic. It's a solution. Oh, she sucks her thumb. Oh, she's just a baby. Pacifiers are normal. We have written these things off. Why? Because we don't know what box to put them in. We don't have a context for them. And as one of my other mentors, Mark Cooper, says, context is everything. So what's the context for these things? What do you think? They all open up the airway, every one of them. So even thumb suck, there are different kinds of thumb suckings. Yes, it could be for comfort. Maybe the thumb on the palate releases some dopamine because the tongue was supposed to be there, but it's not there, so it's really comfortable and we use the thumb. It could be that it's a prop to keep the mouth open, so you know the mouth breathing can continue when you go to sleep. It could be a cranial treatment. I mean, this is what we do in craniosacral therapy when we're trying to open the palate, right? We just put a little pressure upward, goes right up through the vomer into the sphenoid, and we start correcting cranial strains that way. I know they don't know what they're doing, but it gives some kind of unconscious comfort. And maybe just a little bit of sucking pops open the eustachian tube. So each one of these things, you know, can be a useful parafunction, even if it causes unintended consequences like crooked teeth. Will you pour me a glass of water? So now, you guys, I know you're going to know more about TM dysfunction than I do. Thank you so much. But again, yeah, like most of the TM gurus and the stuff that I learned, we kind of attribute it to trauma. Well, yes, there is trauma, but there's a very different way of looking at the trauma that occurs. You probably all know this, so I'm going to go through it really quickly. But it's the same kind of soft tissue dysfunction that creates bad jaws, that creates, that creates collapsed maxillas and craniofacial dystrophy, that creates crooked teeth. It also puts it beats up on the TM joints. So the equal and opposite motion of tongue thrust is distalization of the mandible, and it compresses the joints. In other words, the tongue goes forward, and pregnant pause. Come on. There it goes. The tongue goes forward and pushes, against the anterior part of the mouth, but the tongue is attached to the mandible, and the mandible gets shoved distally. And how many times does this happen? A lot more times than you fall on a coffee table. In fact, probably coffee table and bicycle and whatever accidents, are going to be much more damaging when they're happening to a joint that's been subjected to this kind of treatment. As a compensation for a tongue thrust, the mentalis buccinator pharyngeal constrictor ring of muscles becomes recruited in the swallowing pattern, creating a reining in effect of the mandible and constantly pulling it in. It is like this huge rubber band, a strong one at that. And it goes right around the front of the mouth. And every time the mentalis muscle is activated, and the posterior constrictors, you're like pulling. When I say reining in, think of holding back a horse. That's a constant strain on the growth of the jaw and the joint. A tongue between teeth forgoes the stabilizing effect of centric occlusion, allowing compression of the joint. So let's look at this girl swallow. Slow-mo, instant replay. You see the mandible being shoved back? She may as well have a chin strap on. That's a lot of dysfunction there. So it's activation of that ring of muscles and compression of the joint. You get the orbicularis and mentalis, the buccinators are going, posterior constrictors are going, SCMs and cervical movement, especially if there's a forward head posture associated with trying to keep the airway open. Lateral pterygoid gets stressed and spasmed and whatnot. And that's what's causing all the joint damage. Pushing back on that posterior joint space and dislocating the disc. Steve, most facial pain and jaw joint pathology is the result of repetitive microtrauma. Do you guys all know this? Is this new? Yeah.
You better ask if
they agree with it. Oh, yeah. You guys agree with this? Yeah. Yeah. Forward head posture has a restrictive effect on the mandible because of all the pulling, the poor vectors of pulling of the strap muscles and the super and infrahyoids, cervicals, and so forth. Sorry, I forgot I should have corrected that. I have to click through this. Snoring pulls back on the mandible. Watch this muscle movement. So you've got the hyoids working, but think about what that's doing to the joint. And finally, restriction of mandibular movement from a collapsing maxilla above. It positions the condyle for aberrant forces from dysfunction. Oh boy. Okay, thank you. Do you guys know this one? Airway and TMJ? Jot it down. I'm not going to play the whole thing. I'll start it for you so you can see it. It is a terrific example of the form and function spiral.
Airway and TMJ. The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body.
And then they go through the form and function spiral that occurs. This comes right from that video to open mouth posture, narrow palate, tongue thrust, distalizing malocclusion, disc displacement, muscular tension, parafunctional bruxism, lost vertical dimension, joint degeneration, disc disformation and locking, mandibular retraction, further airway restriction, forward head posture, cervical muscle tension, myofascial pain, and dysfunction. And boy, I know you're all familiar with that, right? And the interesting thing is, it doesn't have to be in that order. You probably have as many different kinds of combinations as you do people, right? It could, maybe the swollen tonsils are not causing the open mouth posture, but the open mouth posture is because muscle laxity is actually irritating the tonsils because you have unfiltered air beating down on it all day long. It may be that the narrow palate makes it hard for the tongue to get up there, but then of course, it could be that the low tongue posture is creating the narrow palate. It could be that the way the teeth are hitting in malocclusion creates this disc displacement, but it could just as easily be with the coffee table, granted, sometimes, that the disc displacement could create the distalizing malocclusion and all that. So, with every major stressor, there could be all kinds of combinations of form and function. The thing about form and function spiral, though, is that you can intercede on either side of the equation, or perhaps with behavior first. But you must intercede on all sides of the equation before you're done. And I think that's the point. All right, cranial and postural dysfunctions. Nasal obstruction can induce physiologic stress by creating these compensations. You got to perhaps hold the head forward or the jaw up or open or forward, whatever it is, to help you breathe better. And then slowly that starts to work into the functional matrix of the bones, not just of the maxilla, but of the cervical bones and really the whole craniosacral system. So, sometimes the problems can start in the jaws and go down to the feet. Sometimes in the feet go up to the jaws, or they could start at the dental chair where we're holding this bowling ball of a head, over a patient for 8 hours a day, their head cocked like this. I don't know how any of us, make it through. How heavy the head becomes when you have to hold it up against gravity off its fulcrum. So then you get to malocclusion, and like I said before, this is just the icing on the cake. I mean, when you think about it, this is the canary in the coal mine. It's just the sign. It's just the symptom of what else, of all those other things that are going on. It is the solution to keep the system in balance. So does that put these things in a little bit different perspective? The stuff we've been struggling with for ages, that it all can be wrapped up in this idea that we have to deal with airway as part of this. So where orthodontic solution is to roll in the compensation, perhaps a better way to do it is to create balance in the body first. And then you can use your damn angle classification.